patient with body integrity dysphoria enters a surgeon's office. They explain that the desire for amputation has remained stable for many years. They understand that the limb is healthy, that the operation is irreversible, and that life afterwards would involve rehabilitation, reduced function, and permanent adaptation. The operation is still refused. Amputation for BID falls outside accepted clinical practice, and this surgeon will not perform it. The patient leaves. 6 months later, the same person arrives in an emergency department after attempting to damage the limb themselves. The injuries are severe. Medical teams now work urgently to preserve the patient's life and manage damage that may have permanent consequences. The surgery that medicine refused to consider under controlled conditions has returned as an emergency. Who bears moral responsibility for what happened? By moral responsibility, I mean who can fairly be held accountable for an action or its consequences. That is different from causal responsibility. The patient directly caused the injury. That tells us who performed the act. It does not settle who bears moral responsibility for the chain of events that led to it. The surgeon refused. The institution offered no accepted treatment pathway. The wider culture helped make the request appear unthinkable. Responsibility may therefore be divided across several people and institutions. Its distribution depends on what each person intended, what alternatives they had, what they understood, and how freely they acted. Today, we will not settle that question. We will build the framework needed to ask it properly. We need to understand what morality is, what makes someone a moral agent when blame is justified, how coercion affects responsibility, and whether a person must have been able to act differently. This is Contested Bodies. I'm Leandro Loriga. Welcome to Episode 8, Moral Responsibility. Today, we examine how responsibility is assigned and why the person who caused an outcome may not be the only person answerable for it. Welcome back. The last 2 episodes focused on the 4 postulates: body harmony, paternalism, and the selective demands for certainty before surgery. We saw that the principles professionals stated did not always fully explain the decisions they reached. Today, we change direction. This episode builds the conceptual framework of moral responsibility. Before we begin, I need to distinguish 2 words that are often used as though they mean the same thing. Morality refers to the beliefs, rules, values, and practices through which people judge action as right or wrong, good or bad, blameworthy or praiseworthy. Ethics is the systematic examination of those moral judgments. Morality is the judgment. Ethics asks whether the judgment is justified. Today, we are doing ethics in order to understand moral responsibility. What does it mean to hold someone accountable for an action? When is blame justified? What happens to responsibility when a person is pressured, compelled, or coerced? Must someone have been able to act differently before we can fairly hold them responsible? What responsibility belongs to the patient? What responsibility belongs to the clinician? What belongs to the institution that offered no accepted pathway? And how do medical skepticism and prior assumptions shape the answer? The framework comes from several influential strands of modern moral philosophy. P.F. Strawson was a British philosopher who examined responsibility through the emotion and social reaction we direct towards one another, such as resentment, gratitude, blame, and forgiveness. Harry Frankfurt was an American philosopher who challenged the familiar idea that responsibility always depends on having been able to act differently. We will also draw on research into moral cognition, the study of how people recognize moral situations, form judgments, and decide how to act. The aim is not to bury the discussion in terminology. It is to give us a clear set of tools for examining responsibility without confusing cause, blame, intention, coercion, and moral agency. We begin with a word surgeons repeatedly use to describe BID amputation: elective. In my interviews, surgeons repeatedly described amputation for BD as elective. The word sounds straightforward, but we need to separate its medical meaning from its everyday meaning. In standard clinical usage, an elective operation is one that can be planned in advance rather than performed immediately as an emergency. It does not necessarily mean unnecessary. Cancer surgery can be elective. A heart operation can be elective. A procedure may be medically important, even life-saving, and still be classified as elective because it has been scheduled rather than performed urgently. In ordinary speech, however, elective carries another suggestion. It sounds optional, chosen, something the patient wants rather than something medicine requires. That second meaning appeared to influence how BID was discussed. Calling the amputation elective placed it near cosmetic surgery and other procedures understood as matters of preference. The patient appeared to be choosing disability despite possessing a healthy and functional limb. The description already shaped the moral atmosphere of the request. Yet the clinical position of BID is more complicated. Psychotherapy, medication, and behavioral intervention may help some patients manage distress or associated mental health difficulties. Current evidence has not established that these approaches reliably remove the central desire for disability. Amputation, therefore, remains elective in the technical sense that it would be planned and non-emergency. Calling it elective in the everyday sense of an optional preference is far more questionable. The patient may experience no effective therapeutic choice at all. The word describes the timing of the procedure. It can quietly be heard as a judgment about the necessity of the request. Why then does the label carry so much weight? Because elective can do more than describe when a procedure is scheduled. In ordinary language, it suggests choice. The patient appears to have other options and to be selecting this intervention voluntarily. That perception changes the moral framing. When a treatment is understood as urgent or necessary, attention usually centers on the illness and the need for care. When a procedure is described as elective, attention shifts towards the person choosing it. Why do they want it? Are their reasons acceptable? Should medicine help them? Are they responsible for the risks and consequences? This does not mean that elective patients are automatically blameworthy, or that patients receiving urgent treatment lack autonomy. It means that the label makes the patient's choice more morally visible. Across my interviews, BID amputation was often discussed in this way. Calling it elective placed the patient in the position of someone choosing disability despite other possibilities. The request then became open to suspicion, judgment, and refusal before the patient's actual circumstances had been fully examined. The word therefore performs quiet moral work. It encourages us to see the patient as the author of an optional and troubling choice. That brings us to the framework we need for the rest of the episode. What does it mean to be morally responsible for an action? And when does responsibility become blame? Not every action raises a moral question. Brushing your teeth, scratching your ear, or parking your car usually carries little moral significance. Context can change that. Parking across an ambulance entrance creates a moral issue because the action may endanger someone. Brushing your teeth with the last available water during an emergency may also affect others. A moral action is therefore an action connected to questions of right and wrong, harm, duty, fairness, care, or responsibility. Augusto Blasi was an Italian-American developmental psychologist, known for studying moral identity and the relationship between moral judgment and action. His work helps explain why moral action involves more than choosing between two options. The person must understand the situation, recognize that something morally important is at stake, form a judgment, and act through that judgment. Feelings, doubts, motives, loyalties, and circumstances all contribute. Imagine a doctor deciding whether to refuse a requested operation. The physical act may be signing a form or ending a consultation. Its moral meaning comes from the surrounding situation. The patient's suffering, the risks of surgery, the doctor's duties, the available alternatives, and the consequences of refusal. Understanding gives the action its meaning. The action then expresses that understanding in practice. Moral judgments are also shaped by culture and history. Communities differ in what they consider harmful, honorable, shameful, obligatory, or acceptable. Medical practices regarded as normal in one period may later be condemned. Conduct accepted in one society may be judged differently elsewhere. Philosophers disagree about whether morality ultimately rests on objective truths, universal principles, human nature, culture, or some combination of these. We do not need to settle that debate here. For our purposes, the important point is that people recognize and interpret moral situations through the concepts available in their social world. The request for amputation and the surgeon's refusal both enter moral territory because each person understands that more than a technical decision is taking place. Questions of harm, autonomy, duty, bodily integrity, and responsibility are already present. How does this apply to BID? My fieldwork showed that surgeons experienced a request for amputation as more than a technical clinical decision. It produced doubt, discomfort, hesitation, and concern about what a doctor should be willing to do to a healthy body. Compare that with adjusting the dosage of a familiar medication. The dosage decision may involve risk and professional judgment, but it usually does not force the clinician to reconsider the meaning of harm, bodily integrity, or the proper limits of medicine. The request for amputation does. That places both the request and the refusal within moral territory. The patient must consider suffering, bodily autonomy, disability, risk, and the consequences of acting or remaining untreated. The surgeon must consider professional duty, harm, consent, bodily function, and whether medical authority should override the patient's judgment. Both are acting within a situation understood to have moral significance. We also need to distinguish a moral action from a moral agent. A moral agent is someone capable of understanding that action can affect others, recognizing questions of right and wrong, weighing reasons, and choosing with some awareness of the consequences. A cat can cause harm. It may scratch someone or kill a bird. We do not ordinarily hold the cat morally responsible because it cannot reflect upon duties, justify its conduct, or understand blame in the way a person can. A competent adult usually can. Moral agency, however, does not make someone automatically responsible for every action. Responsibility may be reduced when understanding, freedom, or control is seriously impaired. Coercion, severe cognitive disturbance, ignorance, and compulsion can all affect how fairly responsibility may be assigned. Galen Strawson, a British philosopher known for his work on free will, takes a far more radical position. He argues that nobody can ever be ultimately morally responsible because nobody created their own character, temperament, upbringing, or original motives. To be fully responsible for what you do, on his account, you would first need to be responsible for the kind of person you are, which leads to an impossible chain. I will not adopt that position here. The working assumption is more familiar. People can usually be held morally responsible when they understand what they are doing, possess enough freedom and control, and act through reason that can fairly be attributed to them. The difficult question concerns the limits. When is agency sufficiently impaired? When does pressure become coercion? When does a desire reduce control? And when are blame or praise justified? We now have moral actions, moral agents, and the condition under which responsibility may arise. The next step is to understand how responsibility is expressed in ordinary human life. For that, we turn to P.F. Strawson and his account of reactive attitudes. In 1962, the British philosopher P.F. Strawson published an influential essay titled Freedom and Resentment. Strawson was one of the major figures in 20th century philosophy. His work on moral responsibility shifted attention away from abstract arguments about free will and towards the way responsibility operates in ordinary human relationships. Philosophers had long debated a difficult question. Can anyone be morally responsible if every action is shaped by prior causes? This is the problem of determinism, the idea that our choices arise from earlier events, including biology, upbringing, character, circumstances, and everything that happened before the decision. If our actions are caused in this way, are we truly free? And if we are not completely free, can blame or praise ever be justified? Strawson approached the problem from another direction. Instead of beginning with the structure of the universe, he began with human relationships. When someone deliberately harms us, we feel resentment. When someone harms another person, we may feel indignation on their behalf. When someone helps us, we feel gratitude. When someone behaves courageously or generously, we may feel admiration. Strawson called these responses reactive attitudes. They are the emotional and moral reaction through which we respond to the intention and conduct of other people. Resentment says, "You should not have treated me that way." Gratitude says, "I recognize the goodwill expressed in what you did." Indignation says, "That person was treated wrongly and I hold you answerable." These attitudes are reactive because they arise in response to how another person has treated us or someone else. They are also moral because they contain a judgment about the quality of the person's intention. Strawson's argument was that moral responsibility is embedded in this network of relationships. We do not first solve the philosophical problem of free will and then begin blaming, praising, forgiving, or resenting one another. These practices are already part of human social life. To treat someone as morally responsible is to treat them as a participant in that life. Someone whose intentions matter, whose actions can express goodwill or disregard, and from whom we can reasonably expect consideration. This does not mean that a person is responsible whenever a community decides to blame them. Communities can blame unfairly. Reactive attitudes can be distorted by prejudice, fear, or misunderstanding. Strawson gives us a description of how responsibility operates. Ethics must still ask whether a particular reaction is justified. That distinction becomes crucial for BID. A surgeon's skepticism, discomfort, or disapproval is not clinically meaningless background noise. It may be part of the moral response through which the patient and the request are judged. The next question is therefore unavoidable. What must be true before that judgment becomes justified blame? Strawson's framework changes what we look for in the surgeon's response. Across my interviews, BID requests often produced skepticism, resistance, discomfort, and hesitation. Some of these reactions may be clinical. The surgeon may be uncertain about diagnosis, risk, consent, or professional liability. They may also contain a moral judgment. Discomfort can express the belief that the requested action crosses a boundary medicine should preserve. Skepticism can reflect doubt about whether the patient's reason deserves recognition. Resistance can communicate that the request appears improper, irresponsible, or incompatible with the duties of a doctor. Through Strawson's framework, these reactions become relevant because they show how the patient is being received as a moral agent. The surgeon is responding to more than the technical feasibility of an operation. They are also responding to what the request appears to reveal about the patient's judgment, intentions, and relationship to their own body. That doesn't mean every expression of skepticism is blame. It means that clinical assessment and moral reaction may become intertwined. My fieldwork therefore examined both the reason professionals gave and the attitudes surrounding those reasons. The reaction may influence which risks receive attention, how the patient's account is interpreted, and how much credibility their autonomy is granted. Strawson helps us see that these attitudes are part of the moral environment of the consultation. The next step is to isolate one particular reactive attitude. Blame. What is blame? And what must be true before it is justified? Blame is one of the negative reactive attitudes described by Strawson. It is the response we have when we believe that someone has acted wrongly and can fairly be held answerable for it. Blame, therefore, involves more than saying that an action caused harm. A falling branch can injure someone, but we do not blame the branch. To blame a person, we usually think that the action reveals something morally significant about how they regarded others, their duties, or the consequences of what they were doing. Philosophers often describe this through the idea of ill will. Ill will does not always mean hatred or a deliberate desire to cause harm. It can also mean indifference, disregard, selfishness, recklessness, or a failure to show the concern that the situation required. Imagine that someone steps on my foot. If it happens accidentally and they could not reasonably have avoided it, blame may be inappropriate. If they do it deliberately, knowing it will hurt, the action expresses direct ill will. If they are behaving recklessly and do not care whether anyone gets hurt, the action may express disregard rather than malice. Blame may still be justified. Ignorance creates another route to blame. Sometimes a person genuinely does not know that their action will cause harm. The question then becomes whether they should have known. If the information was unavailable, their ignorance may excuse them. If they ignored obvious risks, refused to ask basic questions, or failed to learn what their role required them to know, the ignorance may be culpable, meaning blameworthy. Blame can therefore arise from two broad sources: a morally flawed attitude, such as malice, indifference, or recklessness, or a blameworthy failure to understand what one had a responsibility to know. This distinction will become important for BED. If a patient is treated as blameworthy for requesting amputation, what is the supposed fault? Are they thought to be acting with some hidden or improper intention? Or are they assumed not to understand what they are asking for? Those are different accusations, and each requires evidence. Here is how this applies to BED. When a surgeon refuses an amputation request, the refusal may contain both a clinical judgment and a moral response. Skepticism towards the patient can take two broad forms. The first concerns motive. The surgeon may suspect that the patient is concealing something, manipulating the assessment, seeking attention, acting from a fetish, or presenting the request for reasons they are unwilling to disclose. This is not necessarily ill will in the strict sense of wanting to harm someone. It is a suspicion that the patient's intentions are improper, deceptive, or incompatible with the legitimate use of medicine. The second concerns understanding. The surgeon may believe that the patient cannot fully grasp the consequences of amputation. Perhaps they underestimate disability, phantom pain, rehabilitation, dependence on assistive devices, or the permanence of the loss. The assumption becomes,
if they truly understood what this would mean, they could not continue to want it.
These are two different challenges to the patient's moral standing. One questions whether the patient is acting honestly and for acceptable reasons. The other questions whether the patient possesses the knowledge and judgment required to make the request responsibly. My research asks whether either suspicion is supported by the evidence. Is the patient trying to deceive or misuse medicine? Do they fail to understand the consequences? For many carefully assessed patients with BID, neither conclusion follows automatically. Their motivation may be openly described, stable over time, and consistent with the recognized features of the condition. Their understanding of amputation may also be detailed and realistic. The surgeon's skepticism may therefore be responding less to deception or ignorance than to the content of the request itself. Before we can examine that possibility fully, we need one further concept. Does moral responsibility require that a person could have acted differently? Could the patient have resisted the desire? Could the surgeon have responded differently? That brings us to the principle of alternate possibilities. A familiar principle in moral philosophy says that a person is morally responsible for an action only when they could have acted differently. It is called the principle of alternate possibilities, often shortened to PAP. Suppose someone threatens me at gunpoint and orders me to hand over my wallet. My freedom is severely restricted. We would usually place responsibility on the robber rather than blame me for complying. This introduces the idea of coercion. Coercion occurs when another person uses a serious threat or overwhelming pressure to force someone towards an action. It can reduce responsibility because the action may no longer express what the person genuinely wanted to do. In 1969, the American philosopher Harry Frankfurt challenged the principle of alternate possibilities. Frankfurt argued that a person can sometimes remain morally responsible even when acting differently was impossible. He demonstrated this through a thought experiment. Imagine a man called Jones who must decide whether to vote for candidate A or candidate B. Unknown to Jones, a scientist has implanted a device in his brain. The scientist wants Jones to vote for candidate A. If Jones begins to choose candidate B, the device will activate and force him to vote for A. Jones therefore cannot ultimately vote for B. On election day, however, the device remains inactive. Jones considers the candidates and chooses candidate A entirely for his own reason. His values, preferences, and political judgment lead him there without interference. Jones could not have produced a different final outcome. Yet, the reason he voted for candidate A came from him. Frankfurt's point is that responsibility may depend less on the existence of another possible outcome and more on the source of the action. Did the person act through their own reasons, intentions, and values? Or was the action produced by an outside force that replaced their agency? The hidden device removes the alternative. It does not cause the choice Jones actually makes. That distinction allows Frankfurt to say that Jones may still be morally responsible. His action expresses the person he is and the reasons he accepts, even though a different outcome was never available. This framework shifts the question. Instead of asking only, could this person have acted differently? We also ask, what actually produced the action? Did it arise from the person's judgment? Did it reflect their values and intentions? Did an external force take control? These questions will matter for both sides of the BID consultation. The patient may feel unable to escape the dysphoria. That alone does not tell us whether the request for amputation expresses their own considered judgment. The surgeon may feel constrained by professional rules, legal risk, or institutional practice. Those constraints do not automatically erase responsibility for how the patient is assessed and treated. To understand responsibility, we need to examine the source of each action rather than looking only at whether another option was available. Frankfurt's argument has three implications for BID. The first concerns the patient. A person does not choose to develop BID. The desire may feel persistent, powerful, and difficult to escape. That still leaves an important question. How does the person respond to the desire? Do they reflect upon it? Do they seek information? Do they consider alternatives? Do they recognize the possible consequences for themselves and others? A condition may restrict someone's options without completely replacing their agency. The patient may therefore bear some responsibility for how they respond to BID, while bearing no responsibility for having developed the condition. Treating them as a moral agent means taking their reasoning seriously. It does not mean automatically approving the request or blaming them for their suffering. The second implication concerns the surgeon. A surgeon may say that professional standards, institutional policy, or legal risk leave them no choice but to refuse. Those constraints matter. They may greatly restrict what the surgeon can do, and in some settings, refusal may be professionally unavoidable. Frankfurt's framework still asks what comes from the surgeon. How do they speak to the patient? Do they examine the request fairly? Do they offer support or referral? Do they treat the patient with respect? Do their assumption about disability and bodily integrity shape how they interpret the evidence? External limits do not remove every form of moral responsibility. Even when the final operation cannot be offered, the clinician remains responsible for how the patient is assessed and treated. The third implication concerns coercion. Coercion means that another person uses a serious threat or overwhelming pressure to push someone towards an action. Compulsion is different. It usually refers to an internal pressure, urge, or psychological condition that makes resistance difficult. Neither concept works as a simple switch that turns responsibility completely on or off. A coercive threat may greatly reduce responsibility without removing it entirely. An internal compulsion may weaken control while leaving some capacity for reflection and choice. The relevant questions are matters of degree. How much control remained? How clearly could the person understand the situation? What alternatives were genuinely available? Did the action still express their considered judgment? For BAD, we must therefore avoid an easy conclusion. A powerful desire does not automatically mean that the patient lacks agency. It also does not prove that every action taken under that desire is fully free. The task is to examine how the desire affected understanding, control, reflection, and choice in the individual case. Does the patient's request express deception, ignorance, impaired control, or a considered judgment? How much responsibility belongs to the clinician operating within professional constraints? And how much belongs to the institution that created those constraints? Those are questions of distributed responsibility, not a search for one person to blame. Let me gather the framework in one place. We began with the word elective. In clinical language, it means that a procedure can be planned rather than performed as an emergency. In ordinary language, it can sound optional, something the patient has freely chosen despite having other possibilities. When applied to BAD, that second meaning places greater moral attention on the patient and their reasons for wanting amputation. We then distinguish moral actions from ordinary actions. An action becomes morally significant when questions such as harm, duty, fairness, care, autonomy, or responsibility enter the situation. The patient's request and the surgeon's refusal both have moral significance because each may affect another person, and each requires a judgment about what ought to be done. We also defined a moral agent as someone capable of understanding those moral features, weighing reasons, and acting with some awareness of the consequences. Moral agency makes responsibility possible. It does not mean that responsibility is always complete. P.F. Strawson then gave us the idea of reactive attitudes, responses such as resentment, gratitude, indignation, forgiveness, blame, and praise. These attitudes form a part of the way human beings hold one another answerable. A surgeon's skepticism or discomfort may therefore carry moral meaning, although skepticism alone is not yet blame. Blame requires a stronger judgment. It usually assumes that the person acted with an improper attitude, such as malice, indifference, recklessness, or deception, or that they failed to understand something they had a responsibility to know. Applied to BID, the question becomes, is the patient suspected of acting from an improper motive, or are they assumed not to understand the consequences of amputation? Both claims require evidence. Harry Frankfurt then challenged the idea that responsibility always depends on having been able to produce a different outcome. His argument directs our attention towards the source of the action. Did the action arise from the person's own reason and judgment, or did another force take control? This matters for both patient and surgeon. The patient did not choose to develop BAD, but may still exercise agency in how they respond to it. The surgeon may face legal and professional limits, but still remains responsible for how the patient is assessed, treated, and spoken to. Finally, we distinguished coercion from compulsion. Coercion usually involves an external threat or overwhelming pressure. Compulsion involves an internal urge or psychological force that makes resistance difficult. Either may reduce responsibility. Neither automatically removes it in every case. We must ask how much understanding, freedom, control, and reflection remained. That is the framework we will carry into the next episode. When a patient is refused and later harms themselves, responsibility cannot be assigned simply by asking who performed the final act. We must examine the patient's agency, the clinician's choices, the institutional constraints, and the moral assumption shaping the entire encounter. The central idea to carry forward is that a surgeon's skepticism may do more than express clinical uncertainty. It can also carry a moral judgment. The patient's desire is assessed as suspicious, irresponsible, deceptive, or insufficiently informed. Through that judgment, responsibility begins to be attributed to the patient, not only for the request, but sometimes for wanting it at all. The ethical question is whether that attribution is justified. Does the skepticism respond to evidence of impaired understanding, improper motives, or reduced control? Or does it arise because the desired body falls outside what medicine is prepared to recognize? Applied to BD, this framework leaves us with three questions. First, how strongly does the condition restrict the patient's freedom and control? Second, when clinicians suspect deception, ignorance, or impaired judgment, what evidence supports that suspicion? Third, how do the surgeon's own values, professional constraints, and assumptions about the proper body shape the refusal? These questions move responsibility beyond the patient alone. They direct attention towards the clinician, the institution, and the medical culture in which the encounter takes place. Episode 9 will apply this framework to cases of refusal and self-injury. The question will be direct. When treatment is denied and serious harm follows, who is answerable and for what? Next time on Contested Bodies, we apply the framework. Episode 9, Who is to blame, examines the preconceptions and skepticism physicians may bring to BAD and whether those reactions justify the responsibility placed on the patient. That is where we go next. I'm Leandro Loriga. This has been Contested Bodies. Thank you for listening. I'll see you next time. If you enjoyed this episode, please share it and follow Contested Bodies wherever you listen. Contested Bodies is independently written, produced, and hosted by me, Leandro Loriga. The podcast receives no institutional funding or external financial support. This initiative was born from a desire to make invisible lives visible and examine the gray zones of medicine and the human condition. You can support the research, production, and future episodes through the donation link in the description. I'm Leandro Loriga. This has been Contested Bodies. Thank you for listening. I'll see you next time.